But if not, there's not over abundance of second years.
Well, I'll try to sit down and be quiet.
Can you open it, Julia?
Yes, so we are going to start.
We are four seniors here.
Oh, I can't see anything.
Dr. Jacob, we are four seniors.
All right, this is going to be a sprint through endocrine. We are going to move really quickly. So,
One, two,
all right. So remember, pediatric endocrinology is about 3.5% of the test. So it's a significant amount.
3.5%.
Yeah, the highest that something is 4%.
5.
5? Who?
Nutrition.
Nutrition.
Prevention.
Well, some of that is endocrine. I should have even put it there. But anyway, we're going to go through these systems and we're going to go quickly. Just the pertinence. All right, remember the HPA axis. Just put it back to highlight. Remember that dopamine is the main controller of prolactin, which is by negative feedback instead of the positive feedback. But if you have excessive TRH can also be a positively feedback on prolactin and increase prolactin production. All right, we'll talk about the posterior pituitary. ADH is produced by the posterior pituitary together with oxytocin. Oxytocin, I guess, haven't got much effect in most people, or at least that's what we think. But high osmolality will trigger off ADH production, and that will lead to retention of water and lowering of the osmolality. If we have low osmolality, that will lead to inhibition of ADH, so you'll have free water diuresis and the osmolality will return to normal. If you have no ADH or no response to ADH, then we have diabetes insipidus. Diabetes insipidus meaning flavorless diabetes, large volume of dilute urine, and you end up with hypernatremia. If you have excessive ADH, in syndrome of inappropriate ADH secretion, then you're going to have hyponatremia in those patients. So think of it, ADH like a key. It will help to retain the water. The problem is a water problem, not a salt problem, but a water problem. So if you have a patient with hypo or hyponatremia, we'll check the urine osmolality together with the serum osmolality, together with the serum and the urine sodium. If DI is present, then these patients will have a very dilute and abnormally dilute urine for the really concentrated serum. So the osmolality will be like 300 in the serum, and it would be something like more than 300 in the serum, and it would be something like 125, maybe 300. Typically, if you're that dehydrated, then your urine osmolality will be like 600, 640 will be pretty high. So it's an inappropriately low osmolality for the serum osmolality in the urine. If DI is present, then before we hydrate the patient, we want to give desmopressin or DDAVP, and what we're trying to do is to see if the problem is central or if it's peripheral. If we give DDAVP and the problem is a central problem, then in about an hour to 2 hours we'll start having decreasing in the urine volume and doubling of the urine osmolality. If the problem is not a central problem, but a problem in the kidney where we have lack of response to the ADH in the kidneys, then you will have continuous production of the large volume of dilute urine, and that's how we make the diagnosis. If SIADH is present, then we want to restrict fluids. Usually we do insensible loss and urine output, or maybe 2/3 of maintenance for this patient. If you have DI, you want to make sure you give central DI, then we want to give DDAVP, desmopressin, and we want to make sure we hydrate the patient. Remember, this is a water problem, so you need to be given as much free water as you can. All right, moving on, thyroid. So with the thyroid, we have to think about hypothyroidism, which could be congenital or acquired. Acquired hypothyroidism is usually autoimmune in the US. That's the most common form autoimmune chronic thyroiditis, Hashimoto's thyroiditis, all the same thing, or it could be post-surgical or post-radiation. Also, we'll talk a bit about hypothyroidism and some euthyroid problems. So hypothyroidism, if we have a primary problem, it implies that the thyroid gland is the problem. It cannot make sufficient thyroid hormone. In that case, we'll have a decrease in the T4 production, and the TSH will be elevated by feedback. So remember, the TSH, the free T4 and the T4 will go back to the hypothalamus and the pituitary to cause a decrease in the production. But if this is not present, then we'll have an increase in TSH. So TSH is usually very elevated in primary hypothyroidism. Congenital hypothyroidism is seen in about 1 in 3,000 live birth. TSH is usually greater than 25 after 24 hours. That is a positive screen. Remember, before, if we do it in the first 24 hours, you have that TSH surge. So even if the TSH is 75, 80 in the first 24 hours, it's not really a positive screen. Remember, this is only a screening test, so we have to do a confirmatory test to confirm that this is so. And so for the confirmatory test, we usually do a TSH and a free T4. That's where we can see how much thyroid hormone the baby is producing and how high the TSH will be. Usually babies are born asymptomatic, so they don't look hypothyroid. They look like any normal baby, and that is typically because thyroid hormone can cross the placenta from mom and go to baby, and so baby will not look hypothyroid because they will be getting some maternal thyroid hormone. Babies that look hypothyroid are usually severely hypothyroid, but over time what we see, babies start having problems like severe growth and developmental delay, so they wouldn't start smiling, sitting, doing things on time. They'll have things like prolonged jaundice, usually an unconjugated jaundice, constipation. They'll have coarse features like we see with this baby with the very large tongue. They have umbilical hernias and a large anterior fontanelle. These are just some of the problems. Autoimmune thyroiditis, again Hashimoto's thyroiditis, chronic thyroiditis, lymphocytic thyroiditis, all the same thing. Typically the only thing that we see in those patients is a large goiter. And if you check the thyroid hormone level, it's usually normal. That's the euthyroid state of Hashimoto's thyroiditis. But over time, in adults, about 5 to 10% of them will progress to hypothyroidism. Typically, a patient with autoimmune thyroiditis have a family history of thyroiditis, usually about a third of the patients. Females are usually more common than males, and it's frequently seen in patients with diabetes. So about 10 to 30% of all patients with diabetes will have hypothyroidism, and that's why TSH 44 is something we screen for annually in patients with type 1 diabetes, because they are at increased risk of developing this problem.
And celiac.
Sorry?
And celiac now too.
Yes, we do in celiac as well. So yeah, we screen for celiac disease, we screen for thyroid disease every year in patients who have type 1 diabetes. If you have any of those, then you kind of gain screening for the rest later on. So think of autoimmune polyglandular syndrome, Smith syndrome. Typically the patient has diabetes, they have hypothyroidism, and they have adrenal insufficiency. These patients typically have a positive anti-thyroid peroxidase antibody, as well as positive thyroglobulin antibodies, because remember, you have destruction of the thyroid follicles, and these things that were hidden before now become available for antibodies to be formed, because this looks like a foreign thing to the body, and so you have antibodies against this. So these antibodies don't attack or do anything. These antibodies are a result of now something that was previously hidden now become exposed, because you have destruction of the cells. Finding on physical exam, you have growth fall off, very important. So the kid will be growing nicely, and then you have them falling off the growth curve. Just for the height, usually the weight is maintained completely. In fact, they may start looking a little overweight because they're not growing so quickly, and the weight is continuing to be stable, so they tend to have some weight gain, relative weight gain, not obese. So somebody who is markedly obese is most likely not because of hypothyroidism. They tend to have dry skin, mixed edema, and when we do their reflexes, they tend to have delayed reflexes, which we sometimes call hang-up reflexes, because it takes a little while for the relaxation phase to occur. They tend to have coarse hair, brittle hair, dry hair, and this hair may fall off, leading to hair loss. When we do the labs, they'll have increased TSH, low free T4, low T4, and total T3. Hypothyroidism can also be secondary. So remember, primary is in the gland, secondary or tertiary is in the hypothalamus and the pituitary. And typically, when we see that the patient has multiple pituitary hormones deficient, you might see it with a postcranial irradiation. You might see it with a stellar tumor because it's right in that area with the pituitary, or with an absent pituitary gland. Absent pituitary gland we see commonly in this problem with septo-optic dysplasia, where the patient doesn't have a septum pellucidum, they have very small optic nerve, and the pituitary gland is missing or hypoplastic in those patients. Other things that might trigger us off is things like central defects. Like this patient, we see what the defect is here. The patient has a single central incisor. So anytime we see a single central incisor, that would be something to trigger off screening for hypothyroidism. Also things like cleft, especially cleft palate, cleft lip, but more likely cleft palate, that would be a sign that the patient might have hypopituitarism. So we also want to look for that. Alright, so how do we treat hypothyroidism? Usually with the levothyroxine. In the newborn, remember, they need higher doses, 10 to 15 milligrams per kg per day. That's one of the questions that PrEP asks. They'll give you different doses so that you can pick out that dose. So remember, that dose is important. We want to start with a really high dose because we want to keep the patient hypothyroid for as little time as possible. We want to correct the hypothyroidism as quickly as possible to prevent long-term sequelae of loss of IQ points. Whereas in an older patient, we use smaller doses, 1 to 3 micrograms per kg per day. And if it's a long-standing hypothyroidism where you get this patient with a TSH that's greater than 100, we don't want to start at this high dose. We want to start at a really low dose. We'll start at a quarter to a third of the dose, and we'll slowly work them up to the full dose in about 3 to 4 weeks. Why are we doing that? Because these patients, we don't want to cause cardiac problems, because we'll kind of rev them up from zero. It's like a coal engine, and you just go all the way up to, we could have problems with the engine. So we don't want to do this to the patient. And the goal of therapy is to normalize our TSH and our free T4.
At what age would we start using the smaller doses? Like, is there a cutoff, or is it just kind of?
Typically, it's like in the first year of life, they tend to require more of the higher doses. By 2-3 years of life, it will be a little bit less. But we always want to make sure we treat the patient, I was just about to say, to the higher end of the free T4 in the first 3 years of life, because during that time we have brain growth, and with brain growth, we want to keep the patient TSH very high to enhance brain growth. We want to keep them closer to the higher end. We tend to titrate doses up, but for the younger kids, we tend to start with the higher doses so that we can get them normal euthyroid very quickly. But for other kids, we'll titrate up. Alright, hypothyroidism. We're moving on. Causes. So Graves' disease, autoimmune problem, is the most common cause of hypothyroidism that we'll see in the US. We also see hypothyroidism in patients who have thyroiditis, like Hashimoto's thyroiditis. At the beginning of the problem, when you have the destruction of the thyroid gland, the follicles will release hormone that was preformed, and that preformed hormone will give us an increase in thyroid hormone in the serum, and that is called the hashitoxicosis. Usually it lasts for maybe a few weeks it may even go unrecognized by the patient. They don't have a lot of symptoms. Decravin thyroiditis can also be seen when you have like inflammation of the thyroid gland. Typically it's painful, and those patients tend not to have any antibodies. Sometimes we see people using levothyroxine, especially in teenagers, who still in it to cause weight loss because of its weight loss property, and they too might present with features of hypothyroidism. The labs are common to all of them. They'll have elevated elevated free T4 and total T4, and a suppressed TSH. Usually the TSH is suppressed to less than 0.05. And the TSH is a very sensitive assay, so usually down to 3 decimal points, and so we can measure it. But in those patients, it can become quite unmeasurable. Sometimes we cannot even measure any in the serum. Graves' disease, when you think of it, think of a high adrenaline state, that flight or fight type of thing. Patients end up with things like weight loss, irritability, fatigue because they're going fast. So by the end of the day, they're kind of tired. Heat intolerance, diaphoresis, tremulousness, and of course we see the eye signs. So they usually have a big goiter, nice, large, smooth thyroid gland, and that's one of the things they like to ask in the questions. They tell us things like cobblestoning, irregular thyroid gland when they want us to think about Hashimoto's chronic thyroiditis, because they tend to have multiple little follicles. When they want us to think about Graves', they'll tell us a large, diffusely enlarged, smooth thyroid gland. That is what they usually use. Patients tend to present with things like, we went through the symptoms. The other eye sign we'll see is lid lag. So if you ask the patient to follow your fingers up, it will look as if, follows your finger down, it will look as if the lid is lagging behind the rest of the eyeball. So you will see that large portion of white between the eyeball and the eyelid. If you ask anybody to look down, you will notice that you never see that typically. And the other thing we'll see is the kind of stay, where the lid is peeled back from the eyes, and also you get proptosis, where the eye look like it's kind of falling out of the eyeball. Alright, so Graves' disease, the low TSH is usually not subtle. It's really, really suppressed. You have high T4, high TSH. You're going to get autoimmune markers, so we'll have the TSH receptor antibodies, or the thyroid stimulated immunoglobulin, as they also called. We'll see that in those patients. You'll also have anti-TPO. You could also have anti-thyroid peroxidase antibodies or anti-thyroglobulin antibodies in those patients. Treatment options. Methimazole is always the treatment. That's one of the things they've been asking us more and more now, because they want everybody to remember that methimazole is the way we treat this patient. We don't want to use PTU, because PTU have an increased risk of having liver failure in those patients. The thing that presents with liver failure, patients usually come back with things like yellow eyes, yellow skin, or sometimes patients might notice the yellow eyes or the yellow skin, but they will have itching of the skin because of the buildup of the bilirubin in the skin. So we want to make sure we give patients that information. Other thing that we see is it could cause neutropenia, and they might present with fever or just maybe something like a sore throat, so we want to give them warning about that. Also have problems with the sun, photosensitivity with this medication. But the biggest problem with PTU is the liver failure, so we tend not to use PTU as our first line of treatment. We want to use methimazole always as our first line of treatment. There's a common question in prep talking about that, to remind us that methimazole is the treatment. The only time we use PTU really is the first trimester of pregnancy, because methimazole has some teratogenic effects. So we'll use it in the first trimester of pregnancy, then we'll go to methimazole in the second and third trimester of pregnancy. Also, if somebody had already had methimazole and they got some side effect on methimazole, as we transition them to get a more permanent treatment, we might want to use PTU for a week or a short period of time. And with those patients who are going for like radioactive iodine ablation, which is our permanent treatment, we might want to use that. Remember, if the patient is going for radiation therapy, we cannot have the patient in a hyperthyroid state because that could trigger off thyroid storm, because we're going to be releasing a lot of preformed hormone into the circulation, and those patients must be controlled before. Thyroid surgery or resection is our other permanent method of treatment. Remember, medication tend not to work so well. We treat them for 2 years, but after 2 years, about a third of them go into complete remission and will never get back and never have a problem again. About the other third, they will go into remission, but once we stop the treatment, they will revert back, and another third will take a few months, but will revert back.
So for Graves specifically, or to treat the symptoms of the hyperparathyroidism, you could use like a beta blocker.
Yeah, we come into that. That's the coming down to that. All right, so that's the treatment options. Okay, and so typically the patient has a lot of symptoms, especially in patient who has thyroid storm. We want to use treatment that will be symptomatic. So that's where propranolol will come in, and those beta blockers. We also want to use things like iodine, concentrated iodine, so that is Lugol's iodine, iodine in potassium iodide, a very concentrated form. But remember, that can only last for a few days because you get tachyphylaxis after about 10 days and it will no longer work. So we're going to just use it for the first few days. The other thing we'll use is prednisone. That can also help to buy some time during thyroid storm as we prepare the patient for more definite therapy, because remember, methimazole, it acts to prevent the production of thyroid hormone, so it's not going to start acting right away, right?
How does the prednisone work? Does the iodine work right away?
Will work right away. The prednisone, by the end of the day, you might see some results with it. All right, so thyroid nodules.
Does the treatment of the Graves prevent the progression of the ophthalmopathy?
Oh no, it doesn't. In fact, sometimes when you treat Graves, you actually get worse eyesight with the patient, so it doesn't prevent the problem.
It's irreversible.
Huh?
It's irreversible.
Yeah, it's related. Once you have it, you have it. Yes.
The same for the beta blockers, the dose used to control the heart rate, the same dose. Like, will that also have an effect on the peripheral conversion of 14?
It tend to ameliorate the treatment of the adrenaline. So if you have less thyroid hormone in the system, then you're going to have less effect. But in the production, I don't know if it affects the production as much. All right, thyroid nodules. Thyroid nodules, so yeah, remember, yeah. So it with Graves' disease, going back to your question about the eye, the eye sign can predate the thyroid disease, and it can post-date the thyroid disease. So sometimes people might present first with just the eye sign. So the proteoglycans and other stuff behind the eye. Yes, it does. Some people end up having surgery to help with the eyes when you have too much proptosis. The medication and the treatment of the Graves' disease thyroid problem doesn't help the eye. Alright, thyroid nodules. So anytime you see a solitary nodule, or any patient in the questions with a solitary nodule, we have to start thinking of cancer and start working up that way. If you have a diffusely enlarged gland or a gland with multiple nodules, not the same thing. But if you have a solitary nodule, very important. So in the past, we did a lot of uptake scans, and the uptake scan would tell us if it's a hot nodule or a cold nodule, and if it was a cold nodule, then we would go ahead and biopsy or take off the nodule. Now we use thyroid ultrasound. Thyroid ultrasound is very, very easy. The thyroid gland is right there. We can look at it. When you look at it, you can look for nodules. Oops. You can look for nodules, like here we see this very large nodule. This is blood vessel, this is trachea, this is this big nodule, thyroid nodule. And when you look at the nodule, you can kind of get if it has cystic, solid components, blood flow. You can get a lot of information, size, shape, different things that can help us to decide whether it looks more like something we're going to be worried about or something that we're not going to be so worried about. Up to fine needle aspiration is the way to confirm this. So we'll do a fine needle usually on the ultrasound guidance. We'll do a fine needle of the thyroid gland. And up to about 20% of them are malignant, either papillary, follicular, or medullary. If you have a cystic one, just a cyst, that usually looks like a good thing. Usually it's not associated with a cancer. But if you have solid component to the cyst, all bets are off. If you have a positive antibodies like TPO or thyroglobulin antibodies, it's more likely to be benign because patients with Hashimoto's thyroiditis tend to get multiple nodules in the thyroid, and if you have multiple small nodules, it's usually not a problem. But if it's growing quickly, if it's a firm nodule, if you have a family history of medullary thyroid cancer, if you have history of neck radiation, if you have associated lymph nodes, enlarged lymph nodes, that's usually a bad sign. All right, we're done with thyroid. Yeah, thyroid ultrasound would be a more correct answer because that's yes, because that's what we do these days to look at it. We get much more valuable information, and we can also always biopsy if we see something that looks abnormal.
So we don't do optic scans anymore.
Yeah, we do optic scans, but not typically for a nodule. For a nodule, the first thing we'll do is a thyroid ultrasound. So remember, everybody with a goiter doesn't need an ultrasound, right? But a patient.
And they'll take some usual cases to know if it is like the difference.
Hot or cold. So if you're thinking of something, if the patient has symptoms of hypothyroidism per se, and you want to see if that patient having a problem with the release or the forming of thyroid, then you could do it. So if the patient is actually having thyroid hormone being formed, like in Graves' disease, the gland will be hot and very active. If it's something like hashitoxicosis, then the gland will not be hot. The gland will be cold.
Like if they are taking.
Yeah, if they're taking exogenous things.
I came across a question like
yes, so that's another thing they will ask.
Expect like for Graves' disease, like increase uptake and all that.
Right. So for Graves' disease, it will be increased uptake, but typically for all the others where the problem is not a problem of production, it will be less uptake. Okay. So let's move to the go number. Oh gosh. So we talk about ambiguous genitalia. Alright, so remember, normal development, we'll talk about a little bit. So the internal development, we're going to have the SRY is important. If you have the SRY gene, then you have the cascade beginning to produce a male testes, because that gonad is bipotential. It can become a testis, or it can become an ovary when we start it. If it's SRY is present, then you get a testis being formed. Once a testis is formed, then that will produce testosterone as well as Mullerian inhibiting hormone. If Mullerian inhibiting hormone is produced, then you inhibit all the Mullerian ducts, and you have no uterus, no fallopian tubes, none of that being formed. And the Wolffian ducts will become dominant, and you have internal male organ. If you don't have an SRY, then you have the default pathway. Or that's what we think. The default pathway is the production of an ovary. If an ovary is produced, then you have no MIH, and because you have no Mullerian inhibiting hormone, then you're going to have the Mullerian structures becoming dominant, and the Wolffian structures regress, and that gives you a female internally. So SRY is present, male, SRY absent, female. Now if you have those that produce now, the external genitalia is dependent on testosterone. The body don't care where the testosterone comes from. Once there is testosterone, then that's going to lead to fusion of the where's my cursor?
Folds. The
All right,
folds.
fusion of the. Oh, it's
They're
not
the
showing up
folds.
here. No, it's not showing up there. Huh? Oh, here we go. Alright, so if you have this the fusion of the folds, if you have testosterone, and you'll end up having a male genitalia. So remember testosterone, but not just testosterone. Testosterone and its active form, dihydrotestosterone, is what is needed for us to produce a male external genitalia. Female, default. No testosterone, you end up with a female external genitalia. I can't finish it. I have to go with each slide like that. Okay, okay, so yeah, this is it. This is it. Sorry, it doesn't. I can't really use this one. Alright, so let's think of a few things with this disorders of sexual development. So if you have an 46XY and you have a DSD, we have to think either there is a problem with testosterone production, we didn't produce enough testosterone, so the external genitalia didn't get to virilize completely, or we may have had testosterone, but the testosterone couldn't be converted to DHT, or the receptors wasn't working well enough, and that's the problem, right? So think of it as a problem with production or problem with response. If you have a female DSD, and that's XX, 46XX DSD, I should say, then those patients will have, we have to think of excessive testosterone production from somewhere. It could be from the mother, say she had like a luteum of pregnancy or some other tumor in pregnancy that increased the production of testosterone. Or if you have exogenous adrenal androgen, it could be from the mother, it could be from the baby, like in CAH, where you're going to have excess testosterone or androgen production, and so you'll have virilization of the external genitalia. Or we can think of an ovotestes, where the patient has 46XX or 46XY, or a mosaic where they have a combination of 40, maybe XXY, or different combinations where they might have develop an ovotestes instead of a testes or an ovary. Or we have patients who are hermaphrodites who have both testes and ovaries. Most of the true hermaphrodites are actually 46XX.
And why in the true hermaphrodite they develop those organs in
Different things in the cascade, because remember, SRY is just the starting point. There are several other genes in the whole cascade. Alright, so bigger picture of DSD. Testosterone and DHT.